other colleagues, speakers who are going to take us through something more exciting. I have no financial disclosures to make. And I'll start with the definition. Definition of a thoracolumbar fracture is a break. A fracture is a break in the vertebra of the spinal column in the thoracic and or lumbar region. They can be associated with disruption of the ligamentous complex and therefore can result in instability or compression of neural structures. Thoracolumbar fractures are the usual outcome of trauma to that region. And apart from fracture, other outcomes can lead to a traumatic disc prolapse, isolated ligamentous injury, epidural hematoma with pressure on the cord or nerves, although those are rarely happening without a fracture. So thoracolumbar trauma doesn't mean only bony trauma. It can be also soft tissue trauma. How about the etiology? In the modern day is due to falls, and this can be up to 30%. In the elderly, this is now a major cause of thoracolumbar fractures, especially thoracolumbar junction fractures. And in the over 65, the falls are 3 times more likely to be the etiology.
Andreas, we don't hear you.
A significant proportion of gunshot injuries. Now, one point to take into account that if we have a young patient with only mild trauma and a fracture,
okay,
this is a red flag. It's a red flag, and we should start thinking that there may be an underlying sinister process, such as neoplasia, or metabolic disorder, which needs to be ruled out. Now, again, on the basic biomechanics side, we have to remember the orientation of the facets in the thoracic region is more coronal and frontal rather than sagittal, which is in the lumbosacral region. So that is also part of the pathophysiology behind this. This is very basic. I'll skip that, and I'll go to a few basic aspects of epidemiology. The rate of fractures in blunt trauma patients is approximately 7%. The male to female ratio varies depending on who you read. It can be from almost 1.5 to 1, or as big a difference as 4 to 1. But the study that went to 1.4 to 1 had a mean age of about 50 years, plus or minus 17. In elderly patients, we have osteoporosis. We know that in falls, 2.8 to 3 times more likely in over 65 than less. And of course, up to 70% of osteoporotic fractures actually remain undiagnosed. Pediatric population is comprising about up to 5% of spinal injury admissions. In that population, we also have SCIWORA, which is a spinal cord injury without radiological abnormality. But overall, thoracic and lumbar fractures account for 48 and 32% of spinal injuries respectively, and they do happen most commonly at the junctional area between T11 and L1. Multi-level spinal fractures are present in around 1/4 of spinal injury patients, but if it's an isolated fracture, it's a higher likelihood that this is an osteoporotic situation. How about the occurrence of trauma with deficit? 50% or less of patients with spinal injuries have associated neurological involvement. Spinal cord injuries occur in the thoracic region in 17% of cases and 20 to 24% in the lumbar region, but they are always associated injury possibilities. Multi-system injury can be up to 80% and head injury 41%. So always think of ATLS basic guidelines, back to basics, what other systems may be involved. The epidemiology of thoracolumbar junction trauma with injury is not that well described, actually. And this is one of few decent papers that shows in panel A the mechanisms, in panel B the age association with mechanisms and the percentages. In panel C, it shows the completeness or incompleteness of cord injury. And in panel D, the distribution between the cervical, thoracic, and lumbar regions. And again here, the distribution of which levels of injury were associated. You can see a bimodal distribution in the mid-cervical spine and in the thoracolumbar junction. Now, we've said already that between T11 and L1 is the commonest area of fractures, is about 52%. Typically young and middle-aged patients, high energy trauma or low energy trauma. In the trauma systems classifications, anything above 2 meters height is considered high energy trauma. And then some other associated injuries, as already mentioned. It can be in the thorax, it can be in the abdomen, it can be in the pelvis, or in the head. Now, I will not go into classification systems because I know other colleagues are going to cover this, but it's a reminder that this is useful in defining identity, in establishing a prognosis, in treatment decisions. It allows people to speak with a common language, to make comparison of epidemiological data, and it also allows for some prognostication. How about some treatment principles? Non-surgical treatment is a mainstay. I would highlight this, that a lot of the fractures, in fact, up to 70% in our territory are treated non-surgically. We may not even be referred to them, and therefore we deal with a very highly selected subpopulation of fractures. So for us, if there is a less than 30% vertebral body height and less than 10-degree kyphosis, we will treat them conservatively. The old style option, unfortunately, hasn't completely disappeared, and you still hear of patients being advised to spend a whole week or even more in bed rest, whereas now we can mobilize them immediately, either with a brace or without a brace if it's a minor angulation and a minimal vertebral body height loss. But if we're going to use a brace, it should be an extension brace, and we here favor the Jewett brace with a 3-point orthosis. It's in extension, and you can put it over your clothes as opposed to the TLSO jacket, which is uncomfortable. We do give them advice for no lifting for up to 6 months, and of course, some physiotherapy, isometric exercises. What are the goals of treatment? To protect the neurological elements, to restore any function, to decompress any compressive elements, to prevent and correct deformity, to ambulate early against thromboembolic events, and of course to restore the normal biomechanics of the spine. There are certainly advantages of surgical treatment, with immediate restoration of stability, early ambulation, early rehabilitation, and improved efficiency in correcting sagittal malalignment. What are the indications for surgery in our environment? These are all relative and taken in combination for every case to be judged separately. So I take into account the kyphosis. If it's 20 or 30 degrees or more, it's a relevant point. If there's any deformity in the coronal plane, it's another relevant point. If there's 30 or more vertebral body height, and it's something to consider, but certainly more than 50 is an indication for surgery. Ligamentous instability in combination with other things. If there's a severe bone defect, any rotational mechanism, and sometimes, but not always, and I'll come back to that, if there's occupation of the spinal canal. However, if there's no neurological deficit or radicular component, this is something we need to discuss. And of course, polytrauma patients may benefit from early mobilization. A few minutes on trauma networks before I hand over. Here you see the Scottish terrain. It's a large geographical mass, but the population is only 5.5 million. It's distributed mainly along the coast. And you can see, apart from the central belt refers to the area between Glasgow and Edinburgh. The majority of the population lives here. But you can see in squares, 4 major trauma centers, only 4 trauma centers: Glasgow in the southwest coast, Edinburgh in the southeast coast, and then we have Dundee and Aberdeen, again on the east side. I think the geographical reasons, more than the population, were behind the decision to have 4 trauma centers, and of course some politics. But you can see that the rest of the round dots are major trauma units, but not centers, whereas the triangles are pediatric major trauma centers, and there's only 3 of those: in Glasgow in the west, in Edinburgh in the southeast, and Aberdeen in northeast. And the way that trauma centers work, at least in our territory, is that there is centralization of treatment for major trauma. But if there's a need for stabilization of the patient, it can be done in the local units with a quick transfer to the centers. Another example, on the other end of the country, in the south coast of England, you can see there how different trauma centers are in close proximity to each other. For example, here we have in red Oxford, not too far from Bristol, not too far from Southampton, not too far from Brighton, and then of course South London with Kings and Georgia. So these networks take into account the road structures, they take into account the populations around them, the councils, which are basically the social governance networks, and of course the geography. London itself is a particular major trauma system. It only has 4 units, 2 north of the river, the Thames, and 2 south of the river. This also comes into play in how they get funded and commissioned, how they get served by ambulances and helicopters, how they have governance steering groups, specialty groups, performance standard reviews, and so on. And it becomes quite a complicated situation. But overall, there's only 4, if you see in the center, 4 major trauma networks and centers, but around them, this is connected to 35 trauma units. These were launched in 2012, so it's not that long ago. I remember when this was launched in London, when I was leaving to come to Scotland. It's taken 10 years to reach some sort of steady state, whereas in Scotland, trauma centers, major trauma centers, were only introduced 2 years ago. So actually, this is a system in flux. And I'll finish with some evidence-based medicine. What is the evidence for bracing for thoracolumbar junction fractures? I won't spend too much time because I know there's another speaker behind me, but this is questionable. No confirmed benefit, level of evidence 3, but still in wide usage in certain areas and not in others. If you look at burst fractures, orthosis versus no orthosis, you can see that patients using without orthosis, treated without orthosis using early mobilization, similar pain relief and improvement in function for 5 to 10 years. What's the evidence for MIS versus open? Again, this is a question that can be a subject of studies. In this study, it showed that the percutaneous approach showed shorter operative duration and hospital stay, reduced blood loss, reduced infection rates. However, this was not robust in the sense of methodology. Another open question, long versus short constructs. Effectively, I believe you can find studies that support either of these. Traditionally, we were taught in the past to go 2 levels up, 2 levels down below the fracture. Others used to go 3 and 2. And then we moved partly to 1 above, 1 below in certain situations. And now, to be honest, if we can do 1 above, 1 below, and 1 through the index fracture level, that would be my first choice, to immobilize less of the spine. Another open question is this, what I've just mentioned. If I put a screw at the fracture level, how much difference does it make? I think there is a trend that it makes a difference, but it is definitely open to better studies ahead. Another open question is, in the case of fracture dislocation, how long or how short? And another open question is, front alone